This is Addiction Medicine Journal Club. I'm Dr. Sonya Tredici.
And I'm Dr. John Keenan.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. This podcast also offers Category 1 CME credit through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we are going to be discussing an article about urine drug screens and treatment retention. How are you doing tonight, John?
I am doing fantastic. It is July 4th Eve as we are recording this. And so it's the end of a day. I've been up since 7. I've saw 30 patients in the clinic, ate some cold pizza, and now I'm ready to kind of roll with this podcast.
You are a machine. That's incredible.
And I hear the fireworks in the distance, and somewhere in York County, there is some person who is going to sleep tonight for the last time with all 10 fingers.
Yes, the day when the American public dabbles in home explosives.
It's finally here. ER physicians, this is not a drill.
We're sorry, guys. Good luck. Yeah, I live in Gettysburg, so July 4th weekend includes a reenactment of the Battle of Gettysburg. If anyone is in our area and you wish to see generals and soldiers wandering around in Civil War costume, come on down. They're everywhere. So, John, do you want to tell our listeners about anything new in addiction medicine this week?
This isn't kind of like news per se, but it is kind of exciting. I think that I'm going to use some brand names here. Just bear with me. I think we all know that there's 2 rivaling buprenorphine depot companies out there right now. Sublocade, which kind of hit the market first, and then Brixaldi, which is the new player on the block. And I think that they keep trying to compete with what they can offer. A big benefit of Brixaldi has been to date that it can be stored at room temperature. It doesn't require like a locked refrigerator, which for some reason is very expensive to get at the average clinic. However, Sublocade just came up and they said that actually now their product is going to be relabeled that it can be stored at room temperature now up to 12 weeks safely. So that's kind of like a game changer for that product.
No way. That's amazing.
Yeah, 12 weeks. And apparently the packaging was updated at the end of June for the 300 milligram dosage, and the package will be updated as of the end of July. This is 2024 for the 100 milligram doses.
That is game changing. Getting the locked fridge, getting the very high end locked fridges that were sort of approved by our St. Max's health system was a real barrier to offering Sublocade in a lot of our primary care offices.
Especially the lower volume ones. So I think this is really cool. I'm glad that we're going to be able to do this. I think it's going to make it tougher and tougher really to kind of pick. I'm interested to see if insurance eventually kind of drives people to one or the other.
Yeah. Do you have a preference?
I do. Do you?
I don't. I actually see pros and cons of both brands, and I give the patient kind of the options. I see significant differences, not in the core use, because they're both long-acting injectable buprenorphine, injection every 4 weeks, more or less the same, but I feel like the Sublocade brand is a lot more long-acting. So patients who really desire to use it for a taper, that's the product of choice. But the injections are much more difficult for patients. Painful, you get a big lump, you can kind of see it on the outside, whereas the other brand, the Brixaldi, is a much lower volume. So the injection itself is much better tolerated. That's my difference. So I don't say I like one more than the other, but they're different.
I have a preference. I'll keep it to myself, but it's certainly, I feel like I have a very refined process at my office. I'm not a specialty office, right? So my staff does everything from children and newborns all the way up to addiction med. I do hepatitis C. Now I do HIVs. So I feel like I'm always training them in something new. It's really hard to have processes in place for all of these things, to have 9 options for treatment. I have a very refined relationship with one of our specialty pharmacies, and it really works quite well. Everything's kind of runs seamlessly. So I'm almost kind of at the point, if it ain't broke, don't fix it.
Right. You offer what you offer. It works really well. No need to offer everything.
It's like when you see simvastatin on the med list. If it ain't broke, just leave it alone. It's an internal medicine joke there for you.
Totally. Although the residents are the worst at that. They see this less than ideal care on our patients, and they change it all to the most up-to-date, more ideal care. And then I feel sort of dumb as a doctor that I didn't do it myself. They always have the guts to just, even if it ain't broke, to fix it.
I used to do that when I was younger. I feel like now, if it does a good job, it's well enough. Sometimes if you can really break this ship if you change too much too quickly.
Make too many changes. Well, that is amazing news, actually. I'm gonna make sure I get that reference, and I will be letting all of the St. Max prescribers know about that.
How about you? What's new in addiction medicine for you?
So I read kind of a crazy article, and this was something totally new. I didn't know anything about it, which was the subliminal menthol in cigarettes. So, John, did you know that menthol is in cigarettes at levels that are too low to detect the flavor, but subliminally they make the cigarette more palatable and desirable? Were you aware that tobacco companies did that?
No, I was not.
There is low levels of menthol in the cigarettes, and it reduces harshness of smoking. It enhances the other tobacco flavors, and it facilitates more smoking. And it's kind of like, I don't know for sure, but I imagine it's kind of like other products that enhance the desirability and craving for products without you being able to detect them in terms of taste. Another product that does that is caffeine. So caffeinated food products, even if you can't detect the caffeine, are more desirable. You want them more. It's sort of a subliminal effect. And so what's troubling about this subliminal menthol though is that we have, many places, the US not, but other places have banned the use of menthol. But these bans only apply to things that are called characterizing flavors. So flavors that you can taste and that really characterize the cigarette by that flavor. And subliminal menthol is not that. So some countries have banned all additives that facilitate smoking, but not the US. The article, which was in Drug and Alcohol Dependence, also mentioned ways that tobacco companies worldwide evade some of these menthol bans by doing things like impregnating the packaging with menthol. So there's no menthol in the cigarettes, but it's in the packaging. And then enough of it can get into the cigarette to make a difference. I put there's a graphic in the paper. I'll share it with you. It's just this really cool picture showing which companies use subliminal menthol and how much menthol you need to have to be detectable. And the number of companies that use subliminal menthol, it's not like one or two. I mean, it's Pall Mall, Merit's Ultra Light, Benson and Hedges, Marlboro Lights, Kent's, Camels, Winston Lights, Philip Morris uses it. Like it's a very common additive, and it's not being considered as part of the menthol bans because it's not a characterizing flavor. So I thought that was super interesting, and another kind of evil move by tobacco companies to keep people smoking as much as possible.
It's really interesting.
Yeah, I always tell my patients, like, these cigarettes it's not a natural product. Like, it's a highly refined pharmaceutical product designed to basically make you addicted in attacking every sense and now attacking your senses subliminally.
Yeah, I always tell people that, like, when they ask about, like, being natural, I go, like, have you ever had, like, an American Spirit, which is, like, the natural, no products? And everyone's like, yeah, it tastes disgusting. I'm like, that's what the product tastes like in its natural state. It's interesting. I was quick Google search here. I wanted to see because, like, those are interestingly not who I think of when I think of like menthol cigarettes. I mean, like number one, it's still saying is Newports, and I wonder. I don't see that on the list, and certainly I feel like many of my patients that smoke menthol cigarettes. That's kind of their go-to.
Well, right, if you are an official menthol cigarette, you don't need to have subliminal menthol. You don't need secret menthol. You have whatever the opposite of subliminal is, menthol.
Oh, okay, I understand now. Now I mean what you. Okay, that makes more sense now.
So, on that note about how tobacco companies continue to conspire to kill our citizens, do you want to tell us about your article?
Yeah, I think it's kind of an interesting article. It's association of random and observed urine drug screening with long-term retention and opioid treatment programs. It's from Drug and Alcohol Dependence, February 2024. This is kind of good when we presented this kind of live. I thought this had some interesting discussion at the end. Most people kind of vehemently disagreeing with my thoughts on the article as you're reflecting on it, but still good discussion altogether. So, background here, opioid overdose deaths have historically been on the rise in the US. Previous studies have shown that medications for opioid use disorder have been shown to reduce mortality post-overdose. Medications for opioid use disorder patients often face stigma from providers and communities. Opioid treatment programs, abbreviated OTPs, in the US conduct drug testing to monitor treatment, adherence, and substance use with a requirement of at least 8 drug tests per patient per year. That was new information. I didn't actually know that there was a requirement or what the requirement was. Federal guidelines, and I think probably consensus amongst people in the field, really encourage patient retention and discourage involuntary discharges from OTPs. There is significant variation in drug testing frequency among states. Previous qualitative studies have shown that patients in methadone clinics often report feeling stigmatized by observed drug testing, which kind of makes a lot of sense. I think it is very stigmatizing practice overall. Involuntary discharge from methadone treatment is linked to high mortality. Returning to street opioids post discharge from OTPs has previously been linked to an increased risk of fatal overdose. While previous qualitative research suggests some urine testing methods may be stigmatizing for patients, there really is no data to date on the relationship between urine drug testing practices and how this affects treatment and retention in opioid treatment programs. What do you think about that background, Sonya?
Well, the whole question is like, what's the point of us doing urine drug screens? And especially at a methadone clinic, I guess once people get significant take homes, they could be diverting their medication. But like the whole point is to, I guess, catch people using drugs and then do what with that information? Like discharge them from treatment. If you think about it as like the whole point of being in treatment is to help people not use drugs, to fire them from treatment if they do use drugs is kind of nonsensical. So it's like, what is the point of all these urine drug screens? How does it really help us? Does it really help people? And especially observed urine drug screens, it makes you feel like the patients are trying to somehow pull one over on you and pretend they're not using drugs. And they would only do that if the stakes were high, like there was some kind of secondary gain, i.e., they don't want to be fired from treatment, which is kind of understandable. Like if you want treatment, who wants to be fired from it, you know?
Correct.
So I just think it's just really interesting. We do so many urine drug screens and like what's the point, right? What do we do with that information?
Yeah, maybe it's the oppositionalist in me, but I do wonder something I do all the time that I'm not really using that information for, like cataract surgery pre-ops. I wonder like what is the point of this? And I think I was like, is this really an efficient use of resources, time? And then you think about if it has no point, does it really? It's just doing the activity, doing the patient disjustice. I mean, I think these are rational questions that I've thought after ordering several thousands of urine drugs tests I've ordered in my career. So thousands and thousands, I'm sure, actually, now that I'm thinking about it. So, what is the clinical question here? What are the characteristics of methadone-based OTPs that are high utilizers of random and or observed urine drug screens? So, like, what is the background? Like, what type of clinics are doing this? And then what is the association between UDS treatment practices and retention to treatment at 1 year or longer? So, a little bit about this study. It's a cross-sectional secondary analysis that was conducted on 150 eligible opioid treatment programs offering methadone. The study surveyed these programs about their urine drug testing practices and participant retention, and this was done between 2016 and 2017. The study utilized de-identified data from the 2016-2017 wave of the National Drug Abuse Treatment System survey, that's the NDATSS, a nationally representative survey of outpatient substance use treatment programs in the U.S. These were internet-based surveys that were conducted with directors and supervisors of the programs, sampled from Substance Abuse and Mental Health Service Administration treatment locators. The survey included both OTPs and drug-free outpatient treatment centers with a response rate of 86.5%. So most places that were sampled did respond. Eligibility for inclusion and analysis here was that you had to be an opioid treatment program offering methadone, and you had to be an opioid treatment program must have responded to the questions via electronic survey on the randomized and observed urine drug practices and the percentage of patients retained. So they had to not only be like a methadone program, but they also had to respond to the questions, and they had to kind of give answers relative to the two domains of interest. Exposure was this 4-level variable based upon the OTPs were whether they're high utilizers of random and or observed UDSs, and they considered basically a high utilizer of either of those practices if greater than or equal to 90% of client population received those. And this is based upon program supervisor survey response. The two questions that they analyzed out of the survey directly was one, for about what percent of your current substance abuse clients do you perform random urine testing each month, question mark. And number two, for about what percent of your current substance abuse clients do you perform observed urine testing? So those was like the two primary data questions out of the survey.
And they just like asked that question. They didn't collect like objective records or anything.
Now, this is just survey data. So, I mean, we'll get into this. And it's also the supervisors responding.
Mhm.
So as you know, every healthcare administrator has kind of complete knowledge of the practices of their organization and those below them. So
Exactly.
I mean, it's an interesting question. I think it gets down to a little bit. We'll talk about like clinic philosophy, kind of primary drives of treatment. I think it was interesting, kind of more the qualitative component of this, to be quite honest, but we'll get to that. So outcomes, the primary outcome was the proportion of clients retained in methadone treatment for at least 1 year, and they use this kind of as a proxy measure of treatment success. Secondary outcomes, there's a ton of things they looked at. So they looked at the association of different clinic variables with random observed and or lack of UDS collection. So like which one of these kind of met with which one of those practices. One is the quality of the interaction between the staff and clients is more important than getting the task done. So basically, are they looking at relationship outcome oriented, or are they more kind of results or absence outcome related programs? Do you use shared decision making? Monitoring for drug absence ranked as the top 1 or 2 reasons for the clinic conducting urine drug testing. They looked at, does the facility have in-house urinalysis testing? Do they have in-house billing and coding capacity? Have they received state grant funding? What employee size do they have? EMR presence, median UDSs per month. They encourage client detox prior to initiation from methadone, detox from methadone in less than a year after treatment. Do they have a profit status, caseload size per kind of counselor or treatment facility personnel, client insurance status. They also looked at how do policies for involuntary clinic discharge modify the effects of UDS mortality on treatment retention. So is there the presence of a discharge policy at all? Do program discharge for unexpected UDS results at all? So will a UDS result ever get you discharged? And what is that policy if it does exist? They looked at the typical covariates, socio-demographic variables like race, sex, insurance status, region. They looked at clinic factors, which is dual mental health diagnosis, and then basically did this fractional logic regression modeling to estimate kind of the relationship between UDS utilization, kind of methods of utilization, treatment retention, and they tried to account for the different variables in terms of clinic characteristics to see what was most important. What do you think of that trial so far?
I mean, so far it's good. I honestly just don't know a lot of the ins and outs of running a methadone clinic. I don't run one. I've never worked at one. So all this stuff about is in-house billing and coding. Do you have it in-house or not? Or do you have an in-house urinalysis lab or an EMR or stuff like that? I don't know really what that implies. I don't have a sense of a methadone clinic that either does or doesn't have that stuff. So I won't say the clinical question doesn't make sense to me. I just don't have enough background knowledge to understand their choice of outcomes, really.
Is this triad valid? Discuss the next question. So, kind of a little bit about this. The study was funded by a research grant from the National Institute of Health. The authors had a single financial disclosure limited to the National Institute on Drug Abuse as like a financial contributor. Is a cross-sectional design which limits causal conclusions or relationships. The data was obtained from this National Drug Abuse Treatment Survey, and it had a relatively high response rate of 86.5%. Results from the survey are well documented in kind of like the addiction literature otherwise, in terms of validity, in terms of a marker of access and utilization of these programs. So, relatively good data collection source. It was a large database with 150 out of 657 surveyed programs included in analysis. So 424 of the programs that responded were excluded. So they were either not a true opioid treatment program, they didn't offer methadone, or they had missing data on methadone and UDS practices. Survey data was limited to OTP directors and supervisors. So that kind of raises concern that there's some response bias in terms of, do you want to say that your staff values urine drug screens as kind of the outcome of choice for their program, or is it better to sounding that you say you use shared decision making and that you value relationships more? Those are very kind of like buzzwords for leadership. Many of the variables analyzed in the study were proxy measures for clinic philosophy towards treatment and really not direct measures or clinic attitudes, especially with ground level treatment providers. There was a lot of kind of unmeasured confounding bias possibility here. It's basically, not only was there proxy measures of success, but it was also self-reported. So I feel like there were several kind of steps between what's really going on and what data was collected to kind of give a surrogate marker. So you can use associations, but I do think that this was kind of a surrogate for X, which was a surrogate for Y, collected by someone that is kind of a supervisor. So there were various areas of distance there. Data was collected prior to the onset of the COVID-19 pandemic, which had a substantial impact on the shifting risk landscape of opioid use and resulted in changes to OTP policies that definitely changed treatment practices and retention practices. While not relevant to critiquing this trial, the clinical question focused solely on the impact of UDS practice on treatment retention with methadone. I think that it would be valid to say that this could certainly, that's a very different treatment environment than kind of buprenorphine or naltrexone program. So I think that you have to kind of interpret that and extrapolate the results to a certain extent. I think most care is probably provided now outside of these clinics, although I don't know that data off the top of my head. So I think that there's a lot of us ordering UDSs for surveillance that are really not in these kind of rigid programs, which could be different. What do you think? Any kind of thing I missed there or other areas of concern?
No, I mean, I think it's valid. They surveyed 150 programs. They excluded a lot of them, but it looks like they excluded them for really not being eligible for the study, not because they didn't participate. Their participation rate was pretty high. I just think, again, like you said, forget being a clinic director. Like if you asked me what percent of my patients get a UDS, I'd have a hard time telling you what percent, and I could make a guess, but then I'd probably be wrong if I like counted up the numbers actually. So it's weird to have a survey where the survey is asking you about like quantitative stuff. You might as well just like count that stuff directly, you know?
I mean, in respect to the authors, right? They probably didn't have access to that more robust of amount of information. Like this is a surrogate, it's a question, it's a population level question. I think that, ideally, probably in a perfect world, they would love to have access to that, but this is what they had access to.
Well, right. And this survey already exists. Like this database exists and it's been used in the literature for a bunch of things. So it's actually a very interesting question to ask from the starting point of the database. It's just that like if you were designing this trial de novo, this might not be the way you would choose to answer this question.
So kind of what are the results? So let's just talk about the methadone clinic characteristics. The survey, as I said, there were 657 programs surveyed. 424 were excluded to not being like true OTPs offering methadone. 59 were excluded for missing data. So only 150 out of the 657 were included in analysis. The total weighted sample of methadone clients was basically 310 patients was the median per OTP that they surveyed. Demographics were 42% were female, so most male. They said nearly 48.6% had this dual mental health substance use diagnosis. I know the literature kind of points towards about 50%. I find this number incredibly surprising every time because this does not feel representative of my clinic, or I feel like it's the vast majority have some sort of dual mental health diagnosis. I don't know. Do you feel differently about that? Or like every time I see this, it kind of seems appallingly low.
Right. I'm trying to just scanning through my own patients in my head. Do I have any patients who are like doing great and don't have any other mental health diagnoses? I've got one. I mean, I have like 100 and something active patients. Yeah. I mean, they're not all necessarily on treatment, but I really feel like I only have a handful who don't have, between depression, anxiety, bipolar disorder. And then I have a bunch of people with, traumatic brain injury, ADHD, things that affect your mental health.
Yeah. So again, I just, it's very interesting. We get this all the time. Regional distribution, most of the programs were in the South. That was 41%, followed by the Northeast, 25%. West was 19%, Midwest, 15%. Ownership, interestingly, and consistent with what I see, most of these were private for profit, 55%. Variation on UDS practices, the majority conducted some degree of urine drug testing. I thought that's kind of self-explanatory. I'm kind of interested to see if anyone said they didn't do any urine drug testing for like an OTP program. And interestingly, 70% of the OTPs that utilized the observed or high rates of observed urine drug testing, which I think is often considered one of the more stigmatizing type, they were in the South. So do what you will with that information. Patient demographics varied by UDS category. So also kind of interestingly, OTPs without randomized or observed urine drug screens, they had higher rates of African American and Hispanic or Latino clients. So that was kind of an interesting kind of twist there. OTPs with high observed UDSs had lower African Americans and Hispanic clients. So basically there was an inverse relationship between higher rate of kind of minorities and decreased rates of urine drug screens that were observed and randomized. OTPs that highly utilized both randomized and observed UDSs had the highest median number of methadone clients, so they had higher numbers if they kind of utilized both. Interestingly, the median UDS frequency across them, all the OTPs, was about one per month. So, and they said that almost all OTPs incorporated UDS testing. I would be interested to see what's the one that doesn't, but again, they didn't kind of say that. Clinic philosophy. Basically, they talked about patient-centered care scores range from 0 to 3. The overall median score was 2. And that was pretty consistent amongst all the OTP categories. OTPs with the highest observed and randomized UDSs were most likely, with 29.3%, to cite monitoring urine drug absence as a top reason for conducting urine drug testing. So they were 29.3% of the time versus an average overall amongst OL programs of 19.1%, meaning that if you increased drug abstinence emphasis, you increase the odds ratio of kind of observed or random urine drug screens. 61% of OTPs using both observed and randomized UDSs emphasize the importance of quality staff-client interactions over task completion, so kind of relationship over outcome. That was compared to 67.6% overall. This means that if you decrease the importance of the staff-client interactions, you increase the chances of your program doing observed and random urine drug screens. Clinic resources scores range from 0 to 5. Overall score, median score was 2. Seems somewhat consistent with the feelings that resources were on the lower side for these programs. 10.4% of OTPs not highly utilizing observed or randomized UDSs had in-house capacity for urinalysis of UDS samples compared to 3.4% overall, meaning that interestingly, if you had increased your in-house UDS capacity, you actually decreased your observed and randomized urine drug screens. On the flip side, 54.6% of OTPs without high observed or randomized UDSs had access to electronic health resources compared to 71.1% overall, meaning that if you had lower access to EHR, you had an increased likelihood of observed and random urine drug screens. Mostly, I would think that they're probably getting information from other sources to kind of justify and collaborate their care. When it gets down to like the big primary question was about kind of association of UDS practices and retention at 1+ year. So after adjusting for clinic philosophy and resources, long-term retention varied significantly. 68.9% among OTPs who did not utilize high rates of randomized or observed urine drug screens versus 57.2% amongst OTPs who did utilize high rates of randomized and observed urine drug screen. So kind of not surprisingly, kind of more randomized and observed urine drug screens decrease your likelihood of retention to treatment after a year. Long-term retention was notably lower for OTPs with higher rates of UDSs. So 13% lower for OTPs using high rates of randomized and observed UDSs compared to those not utilizing either practices. So again, increased retention with decreased use of these two practices for urine drug testing. It was 10% lower for OTPs using high rates of randomized UDSs only compared to those not utilizing either practice. And it was only 5% lower for OTPs using high rates of observed urine drug testing only. I thought that was interesting that the observed urine drug testing was associated with not as much of a reduction in retention as the random urine drug testing, because I feel like kind of the observed testing is often what people cite as the most stigmatizing and demeaning. Interestingly, they looked at the impact of a discharge policy for positive urine drug screens and their association between testing and retention. And I thought this was kind of interesting. OTPs without a discharge policy showed a larger reduction in long-term retention with randomized urine drug screens than those with a discharge policy. So basically, there's a 10% lower overall statistic. However, it was 17% lower without a discharge policy and only 1% lower with a discharge policy. So basically, if you were going to discharge a patient or a patient was going to kind of leave care over an abnormal urine drug screen, the presence of the discharge policy was actually kind of like a mitigator for patient loss, which I thought was incredibly interesting from this. So increasing a discharge policy presence would increase your chances of retention. A sensitivity analysis was done in several different ways here, and they all kind of showed across different cutoffs and modeling that this was relatively consistent in terms of retention and UDS testing amongst their different models. What do you think of that?
It's a lot, it's a lot. I mean, I guess what I just keep thinking looking at all these is these are just sort of associations, they're not causal. And so if a patient who's doing badly in treatment, maybe they get more urine drug screens because they're coming in more frequently because 'cause they're not doing well, or, like, if you get 1 urine drug screen and it's positive for whatever, then you're told to come back in a week instead of 2 weeks with your take homes, and then you get another urine drug screen. So suddenly you got 2 a month, whereas if you were doing well, you would only get 1 a month. And so I think it's just you gotta be careful with the story that the data tell, you know? I mean, it doesn't tell the story that doing more drug screens leads to shorter treatment, less treatment retention necessarily. That could be one option. That's one story it could tell, but there are other stories as well.
Yeah, I just think that, like, I would say the takeaway here is the association here is that this highly expensive, sometimes stigmatizing, often non-value added practice does not seem to have an association with improved retention or improved, like, surrogate outcomes here in this study, which is kind of counterintuitive to something we put a lot of effort into.
Well, it is, and if you asked yourself, "Hey, why would what's the plausibility here? Why would urine drug screens improve retention and treatment?" I have trouble thinking of a reason unless I were gonna fire the patients if the urine drug screen were positive, but then you would think that it would just lead to people leaving treatment. So, like, I can't even think of a way that it's sort of ridiculous to say because it's like a mainstay of addiction treatment, but, like, what's the point, you know? How could it lead to better treatment?
I mean, kind of summarizing this up. So, like, I'm a family doc. I do addiction medicine and I have some chronic pain patients as well. I do a lot of urine drug testing. My clinic does predominantly involve buprenorphine, naltrexone, probably buprenorphine the most. So, like, it doesn't kind of directly correlate to this trial of outpatient treatment programs for methadone. I do question this a lot, like, as I've discussed. I feel like I wonder, like, I order so many of these. I know that, like, it's a very tedious process. I know my staff really struggle with keeping up with this very busy clinic, getting all these drug screens. I think that oftentimes when there is an issue, it often results in a patient kind of filibustering the drug screen for like 45 minutes, sitting in the room that they can't pee. And it ends up being this kind of slow down to the clinic where really it slows down the real meaningful conversation here. So, like, I don't really think it adds so much all the time. And to be honest with you, it almost never affects, like, my true treatment plan, right? I think maybe when I was younger and I was a little bit more focused on urine drug screens as outcomes for patients, it probably did. And probably that was when I was not a good of a doctor as I currently am at what I do with this, right? I think that that was an evolution of my care for patients with this condition. But I think it's something that definitely kind of warrants reconsideration. I find it really kind of most surprising that the UDS policy kind of mitigated some of this patient loss, because that seems incredibly counterintuitive to what we normally think of with addiction medicine. I think that, everyone always uses the terminology, like every conference, about individualized recovery tailored to a person's personal cultural beliefs, their own spirituality, and their feelings of the world around them. So normally the kind of the theme is always tailored, individualized care, not cookie cutter, one size fit all policy. So I find that very interesting, and I would love to somehow kind of explore that further.
Well, right, and it is interesting because theoretically, the point of all these urine drug screens is to encourage people not to use drugs, and then they would not use drugs, so they would be in treatment longer. Like, theoretically, that's what they're for. So, if you have a policy where people know about it and they avoid drug use because they don't wanna be discharged, then sure, like, maybe discharge policies could be related to longer retention and treatment. I just feel like what we've seen with, like, illicit fentanyl now on the market, there's no consequence that's strong enough to keep people off drugs. Like, forget being discharged from treatment. Like, if you use drugs, you could die. And even that's not enough of a threat to sort of keep people from using. So the threat that you'll be discharged from treatment is a little weak in the face of, like, massive fentanyl effects.
Yeah, and after we had a lot of heated discussion, and I feel like that, questioning the urine drug screen at the journal club didn't go over well with our colleagues so well. But I think that, rethinking about it, how you use it, is something I have done. And kind of in full transparency, one thing I've kind of started to experiment with just kind of the past 2 weeks in my clinic is, instead of doing this kind of one size fit all for everyone getting a drug screen, we've started doing a random, every patient's assigned a number. We're doing a random number generator and we're randomly selecting half the patients, and we're going to see how that goes. And I'll tell you, it's been amazing how people have just like, Dr. Keenan he doesn't want a drug screen today. Oh, and they're like taken back and like surprised and like, they're like, this is great. Thank you so much. And it's like, they feel like I'm like trusting them, and I do trust them, but I feel like, some of them, especially the long-term stable people, that was really like a positive thing for them. Like I almost feel bad about my practices to date.
Well, I'm glad you're doing a random number generator. That's very honest. So you're not using your bias to sort of do screens on people who you have some sort of gut feeling about. You're really trying to make it unbiased.
Currently, yes. We'll see how this works out for me.
I end up doing urine drug screens like every other-ish visit for my patients. So in my clinics, I do video visits every other visit. I alternate between video and in-person. And then a small percentage of my in-person visits get switched to video because of transportation issues or whatnot happens, so the patient can't come in. So I'm probably a little more like 5/8 video for a lot of patients. And so they don't do a drug screen when they're on video. So it ends up being about half of the visits get a urine drug screen. And for patients who are super stable, they're only seeing me every quarter anyway. That can be like 2 a year for my most stable patients, which isn't very much compared to like 8 a year mandated for methadone clinics. But I will say, we're talking real negative about urine drug screens. I actually thought hard about, should I even bother continuing them, and I decided to do it because I feel like they allow me to have conversations with people about drug use. And I think, and I'm not going to blame the patients. I think they are so used to being stigmatized and punished for drug use, and they are used to lying and hiding their drug use from authority figures or people they want to put a good face on it for me and for our recovery counselor that they're doing well. And they would not tell me about the drugs they're using. And I really need to open up conversations with people about their cocaine use, their methamphetamine use. Like I can't really help them as well as I would like to if they're not telling me what they're actually doing. And I have people who are like obviously intoxicated in the office. They're so not right and not well. And they swear up and down they're not using any drugs. And then they do a urine drug screen as positive for, be positive for buprenorphine, cannabis, methamphetamine, amphetamine. And I'll say, you sure you didn't use something just a little bit? And then it all comes out. And then I can actually help them and say, hey, well, let's talk about this. So I actually do find that the urine drug screen, while it never causes me to fire anybody from treatment, it does change the conversation for me. Have you found that, John? Or do you feel like people tell you what they've used and the urine drug screen doesn't add much?
I think the urine drug screen adds a little early in our relationship. I think not so much anymore for some patients. Although occasionally, I guess it does add something.
Well, thank you for presenting that article. I thought it sparked a lot of really great discussion about overall our use of urine drug screens. And I kind of look forward to more information. It reminds me of these articles I've done with the residents about improved glycemic control with finger sticks, like finger stick glucose. There's a bunch of big trials that show that if you check your blood sugar at home, if you're a well-controlled diabetic just on oral medications, you actually have worse outcomes than if you never check your sugar at all. And everyone's just sort of blown away because it's kind of counterintuitive, but maybe it's the same thing. So I do have a comment for our talkback section. It's not really a talkback comment. It wasn't a comment someone sent in, but I wanted to bring it up anyway. So we did episode 20 way back when about targeted naltrexone, which is taking naltrexone when you feel the urge to drink rather than off every day. And there's another addiction medicine podcast called Addiction Medicine Made Easy by Dr. Casey Grover. And he reviewed that same article on his podcast, also talking about targeted naltrexone. And I learned something new from his take on the article, which was that he uses targeted naltrexone on top of daily naltrexone. So people take naltrexone every day, and then if they need extra coverage, they could take a targeted naltrexone at time of increased cravings. And he said he uses that a lot, and I had emailed him, and he was very nice to explain to me what he does. So he has some interesting comments about that article, and I'll put a link to his podcast in the show notes. So it's kind of like asynchronous journal club. Over the course of the year, other people have chatted about the article, so very slowly we're gathering different opinions. So if you reviewed that article that we did in episode 20 about targeted naltrexone, or you read it and have thoughts, even though it was a year ago, you can still let us know what you think. Thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media or join our Facebook group, and the links are in the show notes. Our original theme music was composed and performed by Benjamin Kennedy, audio editing by Aaron McHugh, CME support from MyCares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation. Have a great day.